Exactly. So thank you so much. So we will try to discuss genetic background and response to Sotatercept. These are my conflict of interest. So very shortly, very briefly, we have a lot of genes that have been involved in heritable pH, where all these genes are considered to be associated with pulmonary arterial hypertension. And the most frequent mutation observed in heritable pH is BMPR2 mutation, the first gene that has been discovered in the field of pH. What is exactly BMPR2? BMPR2 is a protein, a receptor that plays a role of brake for proliferation of cells in the pulmonary vascular bed. So when BMPR2 works, it plays a role of brake and avoid proliferation of cells of pulmonary arteries. But when you have a mutation of BMPR2, you have no brake, and there is an increase of the proliferation of cells that progressively induce pulmonary arterial remodeling and pH. What we know about BMPR2 mutation carriers is that patients pH patients who carry BMPR2 mutation had a severe form of pH, more progressive form of pH, and usually they are younger and with more severe hemodynamics at diagnosis. One point that is very important is that, in fact, of course, when you have a mutation in BMPR2, this pathway is abnormal because you have the mutation, and so the expression of BMPR2 is very low. But it was also the case for patients who have other form of pH or idiopathic pH without mutation. That means that BMPR2 pathway is abnormal, not only in patients who carry the BMPR2 mutation, but also in all forms of pH. That may clearly potential target to treat pH because we know that BMPR2 is abnormal in all pH patients. During several years, we tried to correct BMPR2 expression by different pathway, but no treatment achieved to restore BMPR2 pathway in pH. And more recently, we discovered that BMPR2 is not an only pathway, but it's a balance between BMPR2 pathway that play a role of brake, anti-proliferation, and activin pathway who play the role of proliferative effect. And in healthy subject, it's a balance between this anti-proliferation and proliferation in healthy subjects. But in pH, we know that there is a decrease of BMPR2 expression, decrease of the BMPR2 pathway, but also we discovered that there is an increase in activin pathway. So there is clearly an imbalance in favor of proliferation of cells. We are not able to target directly BMPR2, but with Sotatercept, we are able to target the ligands of the activin pathway. That means that we are not able to increase the BMPR2 expression, but we are able to decrease the activin pro-proliferative pathway and restore the balance. And so we restore the normal proliferation of cells in pulmonary arteries. So there is a question about patients who had BMPR2 mutation. Should this patient respond better than the other or not? It was an open question. So in this study that I will present to you, we will look at what is the response to treatment to Sotatercept in patients with BMPR2 mutation and in patients without BMPR2 mutation. It was published this year in the American Journal of Respiratory and Critical Care Medicine. And it was data from PULSAR study. PULSAR study was a phase 2 study, a double-blind, placebo-controlled clinical trial that evaluates the effect of Sotatercept versus placebo in patients with PH. And in this study, we decided to look at the genetic background and to look if it changed the response to treatment. To do this study, we exclude patients with connective tissue disease because it's a different response to treatment. And we know that there is no genetic background in these patients. So we compare patients with idiopathic or heritable or familial PH. We have no pathogenic variants, no genetic background. And we look at patients who carried genetic variant, and it was BMPR2 for 23 of these patients. And we compare the response to treatment, but also the safety of treatment. What we saw, but it was known that BMPR2 patients were younger at diagnosis, at the severe pH, and they are more prone to have triple therapy, and they had a lower NT-proBNP, probably because they had more aggressive treatment and they are younger than the others. And if we look on the answer to Sotatercept, the efficacy of Sotatercept in this patient, there is no difference regarding the genetic background. If you have a BMPR2 mutation or no BMPR2 mutation, the good news is that you can respond to treatment by the same way, with a decrease in PVR, an increase of 6-minute walk distance. The only difference is for NT-proBNP, a biomarker of right heart failure, because there is a lower decrease in patients carrying a BMPR2 because they are a lower level at baseline, so they cannot decrease. But if we look at the final NT-proBNP, is totally similar in the two groups. That means that the patient reach a low risk of level of NT-proBNP in BMPR2 patient and patients who do not carry BMPR2 mutation. There is a question about the safety of Sotatercept because there are some adverse events and particularly hemorrhagic complication. And there is no difference between patients carrying BMPR2 or who have no, and patients who have no mutation. The same proportion of serious adverse events. That means that it's safe, whatever is the genetic background of the patient. Another information for this study is that we identified 2 patients who have a specific pathogenic variant, not BMPR2, but other pathogenic variants. And of course, we cannot have definite conclusion based on only one case, but it can give some information for clinicians. We have a patient with ACVR1 mutation and a patient with B allelic EF2AK4 mutation. ACVR1 is very interesting because it's a gene, predisposing gene of PH, but also of hereditary hemorrhagic telangiectasia, HHT, Randu-Osler disease. And we know that patients with carrying ACVR1 may be at risk of hemorrhagic complication, and we do not know if they can respond to Sotatercept. It's only one patient, but what we can see is that this patient with ACVR1 mutation had a good response to treatment, a decrease of PVR, about 2 Watts unit, an increase of more than 100 meters on Sotatercept, and a huge decrease of NT-proBNP on treatment, and there is no serious adverse events during the study. So it may bring some information, but it's only one patient. The second patient had B allelic EF2AK4 mutation. This mutation predisposed to a very specific form of pulmonary arterial hypertension that is called pulmonary veno-occlusive disease. And in this disease, to date, we have no proof that the current treatment we use in PH were useful and safe. And so usually these patients require lung transplantation and they do not respond to treat vasodilators to date. And interestingly, there is one patient in the study with heritable pulmonary veno-occlusive disease, and you can see the answer to treatment. We also observe a significant improvement in PVR to reach PVR of 2, an improvement of 6-minute walk distance, and the patient keep a very low NT-proBNP and no serious adverse events. So also it brings some information for this rare form of PH in which we have no treatment, that sotatercept may have an effect also in this form of PH. And finally, in conclusion, we saw that patients who carried BMPR2 were younger and are more prone to be on triple therapy, higher 6-minute walk distance and a lower NT-proBNP at baseline. But the treatment effect of sotatercept on resistance and 6-minute walk distance was consistent across patients with BMPR2 mutation and patients without BMPR2 mutation. The adverse profiles was also similar in the two groups, and we have some information about rare genetic variants. But of course, we need more data in the future in patients treated with sotatercept. But it's very interesting study because it was the first study where we have the genetic background and look at what is the response to treatment. And I think for the next study in future, probably genetic testing may be done for this patient to see if one day we are able to have a personalized medicine, to choose the good drugs for the good patients and not to treat all PH patients by the same way. Thank you very much.
Thank you very much. Do we have any questions right now? Bruno has a question. About 10% of patients show a super response to sotatercept. Which factors are associated with this pronounced benefit? Are there any genetic hints?
We have not the answer to date. Probably we should collect all these super responders. I'm not sure what is really a super responders because, of course, sotatercept is added on top of patients who have triple therapy or dual therapy. So we do not know if these patients will have the same response if they had not the other treatment. So it's probably the combination that leads to a super response. But of course, I think we should collect data from this patient, and I'm quite sure that we should better phenotype the good responder for all drugs, in fact, and for the future drugs to try to define what is a good patient for the good drugs and to go to personalized medicine. But to date, in PH, it doesn't exist. If we go in another field, for example, asthma, we decided the drugs according to some blood samples, biomarkers. But to date, we are not at this stage in PH, but I think it's the way we should go in the next years.
Great, thanks. And then we have one very specific question, and just say if you don't think you can answer it. Can sotatercept be affected for PVOD PH? It's also called veno-occlusive.
So the question is, yes. We know that in pulmonary veno-occlusive disease, of course, we have some specific mutation, but if we look at the expression of BMPR2 in this patient, is also abnormal. So I think we have quite no data about activin, but we can imagine that the imbalance between BMPR2 pathway and activin pathway is maybe also abnormal in pulmonary veno-occlusive disease. So I think we should work to confirm this data. And if it was the case, we can imagine that sotatercept may be a new drugs for this orphan disease. And you know that vasodilators such as ERA, PD5 inhibitors of prostacyclin can induce pulmonary edema in these patients, but it was not the case for a treatment that could target directly pulmonary vascular remodeling. So it opened an area of research, but we cannot conclude based on only one case, of course.
Mm-hmm. Yeah. Great. Thank you so much, Professor Montani, who is a professor of respiratory medicine.